as introduced, my name is David Sando, and according to the presentation, I was supposed to actually present on the novel approaches for prevention of HIV among high-risk youth. At MDH, as one of the implementing partner, we support the implementation of DREAMS program and other adolescents focused programs that are meant to reduce the risk of HIV acquisition. And in my presentation today, I would take you briefly through some of these, some of the work that we do. So briefly, as we know, yeah, I'll try to do what is possible because of the time, probably. Yep, that's very helpful. So, as we know, and it has been discussed, actually, HIV still remains to be a big issue. And as we look now at the epidemic, it's becoming more concentrated to certain strata of the population, and adolescents are actually one of the most affected subpopulation. We've seen a lot of good outcomes, but unfortunately, adolescents have not really enjoyed the benefit of so many efforts that have been put in the investment in HIV. We know that 63% of new infection globally occurs among girls and women. We also know that 6 out of 8 new HIV cases actually happens among adolescents. And when you zoom into adolescents, girls and young women, these are 15 to 24, girls are more likely to be infected or to acquire HIV as compared to boys of the same age. And according to the Tanzanian HIV Impact Survey, we know that the incidence of HIV among adolescents has not gone down for quite some time, and they still also have higher prevalence of HIV compared to other subgroups in our population. And as my colleague have actually discussed about the adolescents, girls and young women, we know that the risk of acquiring HIV infection biologically is higher, and this is because they have immature cervix. They also suffer a lot of forced sex because of their age and position in society, lack of voices, but also the disparity in age between them and their partners, the genital mucosal disintegration due to a lot of high risks or rates of STI infection. When we look at the HIV prevention in general, there are 5 main pillars that kind of like drive the framework that is used to developing prevention interventions. And one of these focuses on the key population, which is the combination prevention. And this includes also harm reduction packages. And in country here and so many other sub-Saharan countries, we have these packages that focuses on sex workers, men who are having sex with men, PUIDs, and also prisoners. But also another pillar is adolescents, girls and young women, as we've actually talked about. And this is really based on the differentiated layer packages. The third pillar is on the adolescents, boys and young men combination, which this happens or it's more recommended in setting with high HIV incidence. And for this one, the major focus is on voluntary medical male circumcision and also promoting access to HIV testing, care and treatment services. The fourth pillar is on condom promotion. And in this one, actually, the focus is on promoting and distributing male and female condoms And now lubricants has also been added as one of the components in this pillar. The last pillar is actually the ARV-based prevention, which at MDH and many other partners here we do is promoting access to pre-exposure and post-exposure ARV prophylaxis, and these are given most to those who are engaging into high-risk HIV activities such as sex, and we make it available around, in communities so that they're easily accessible. But also treatment as prevention and PMTST they're also included in this pillar of ARV-based prevention. So the idea is really to make sure that 95% of all adolescents who are at risk of HIV acquisition have equitable access to and use appropriate, prioritized and effective combination prevention options for HIV prevention. Next. Yeah, so when you look at actually delivery platforms that have been actually used in different settings, we have community-based and community-led outreach programs in HIV prevention, but also we have health facility-based targeted prevention, and this include sexual and reproductive health education and services. Schools have also been used as a potential platform to access these adolescents for HIV prevention approaches, but also private sector virtual platform and other innovation, as was discussed by Rama, such as creative arts and so forth. Among the enablers that we have seen so far as implementers really is the sexual and reproductive health and rights. That's key, making sure that these adolescents have access to SRH rights. Issues related to gender equality, it's important if we really have to make sure that we have really effective and optimized HIV prevention services to this group. Stigma and discrimination is still a problem, so ending is really key principle to achieving the HIV prevention goal. Creating conducive environment and policies, multi-sectoral integrated and differentiated approach, but also continued sustained investment in HIV prevention. Next, please. So as the previous presenter have actually mentioned, under DREAMS project, the DREAMS stand for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe. Its evidence is a group of evidence-based interventions that have proved to reduce HIV infection among vulnerable adolescents, girls, and young women. And we know, as I've said, they are highly susceptible. Their risk of HIV acquisition is higher. And combining with some of the biomedical, behavioral, and structural barriers, it puts them on higher risk. And because of that, we have a selective number of interventions that are provided to them. And if we move to the next slides, I'll take you through. So the focus of the interventions are really into four main areas. One is to make sure that adolescents have access to safer sexual behaviors. We also have interventions for that targets male partners, because we understand that unless the male partners also practice safe sex and observe, or rather health behaviors, the adolescents or the adolescents, girls and young women will not be safe. Making sure that social protections, the environment and the enablers for social, to make sure that these adolescents have socially protected, but also biological protection from HIV. And within the safer sex, we focus on delaying sexual debut, making sure that they have fewer sexual partners, and even among those partners, making sure that they are empowered to choose partners with low risk of HIV. We also have income generating activities that targeting to empower them economically so that there will be less transactional sex, empower them on the use of condom, but also delaying first pregnancy. And within the male partners, The focus is really also to empower their understanding, knowledge in terms of HIV testing, making sure that they also have access to services such as voluntary male medical circumcision. In terms of the social protection, also is keeping girls in schools to support them financially, delaying marriage and reduced violence. But also in terms of biological protection from HIV, we are increasing access and on HIV testing services, but also post-exposure and pre-exposure prophylaxis. So these are the focuses actually of the intervention that we provide to adolescents with higher risk of HIV acquisition in our program, and in general, these forms some of the key principles or rather scope that most of the HIV prevention services are being offered to. Next, please. Yeah, so I won't go into the details because of time, but we actually, so the core packages, these slides show the core packages for the adolescents, girls, and young women. We also have a package that targets their families, their partners, and the community in general. Next. Yeah, so in addition to this, I also thought I should share, this is one of the analysis that we did, and it actually stemmed from some of the funding opportunity that were just shared from HIS, where we took a grant to conduct a pooled analysis of the data that was coming from the incidence HIV impact assessment from 4 countries of sub-Saharan Africa, where we looked at access to HIV testing and male circumcision services for or among adolescents 15 to 19 in 4 countries. These are Tanzania, Eswatini, Malawi, and Zambia. And yeah, so for Swaziland, we used Swaziland HIV Incidence Measurement Survey that was conducted in 2016 and 2017. For Malawi, we used the Malawi Population-Based HIV Impact Assessment data. We also used Tanzania HIV Impact Survey data that was done in 2016 to 17. And for Zambia, we also got data sets from the population-based HIV Impact Survey that was conducted in 2016. And briefly, I'll show you the results that is probably relevant to our discussion today. Next, please. Yeah, so in terms of, percent of adolescents who have tested for HIV, and we looked this, 15 to 19 years, we see that Eswatini had the highest actually number or proportion of adolescents who had ever tested, with over 76%. But you see that the numbers actually varies significant. In Tanzania, which is actually the first bar here, is only 43% of the adolescents, 15 to 19, who have tested for HIV. And it really varies when you look between the age 15 to 19. 15 is really less than 20%, and that goes up all the way to around 60% for 19 in Tanzania. So Tanzania was the lowest, and Eswatini had the highest. Malawi and Zambia were somewhere in between, with both an average of 53% of the adolescents actually tested for HIV. Next. Yeah, this is also for another slide that shows the percent of adolescents who were tested for HIV, but here we are looking for urban, rural, and also gender. Sorry for the labeling. I think there was a mistake here. It's not a circumcision, it's HIV testing. But when you look here, what you see is actually there was a variation, a notable variation actually between gender, with boys having the lowest rates of HIV testing across all countries. And this is explained partly because of the early pregnancies and access to uptake of antenatal clinics among girls, where they are exposed to HIV testing as compared to male, but with so many other factors. But also being in rural area was associated with lower rates of HIV testing. Next. Yeah, this one now shows the circumcision rate, and it is actually disaggregated by wealth and country of residence, but For circumcision, the picture was different. In Tanzania, Tanzania have the highest proportion of adolescents who were male, adolescents who were circumcised, 84%. And the lowest was actually in Malawi and Zambia, where only a third of them were circumcised. And we found that wealth, age at first sexual intercourse, education level, residence were all associated with being circumcised. Next. Yeah, so these are some of the challenges. Maybe to wrap up, despite all this, we've continued to see increased HIV vulnerability among adolescents in high risk, especially adolescents, girls, and young women. We've also continued to see inadequate access and the disparities in terms of access to SRIH service utilization, both from the studies we do, but actually from the experience on program implementation. We still have a lot of structural barriers that hinders access to some of the interventions, such as income generating activities and also skillful training for adolescents so that they're empowered to start their own income generating activity. Also, as you've seen, also most of these interventions that we're giving, it's a package of intervention that were tested elsewhere. So really understanding, lack of implementation science to understand which of those interventions are the best fit for a particular context is not there. So we provide a salad of intervention that some of them might not be necessarily the right fit for the context that we're implementing, but there's lack of evidence to show of all those interventions which one should be given priority given the context, and I think that's one of the biggest gap. Otherwise, thank you so much, and for the interest of time, I'll stop here. Thank you.